It's always a real pleasure to be asked to speak at these events. And if you're not familiar with the Melanoma Network of Canada, you should be. They're a really classy organization that really provides tremendous support to patients. And what neither Evan nor Mary commented on was their growing role in patient advocacy in the drug approval space. So one of my patients sits on a board, a national board that is essentially responsible for deciding which of these new cancer therapies is ultimately approved so that we can access them for our patients. And having patient input into the process is really critical. And groups like Melanoma Network of Canada are responsible for providing a coherent voice, a cohesive voice for patients. You know, I have about maybe 30 or 40 slides that I'll go through. Cam in the front row is my friend and my patient, and he's seen this 11 times, so he's only here to heckle tonight. I'll go through these. Slowly, but I would invite you to ask questions along the way. So, what we're going to talk about is the mechanism of action of some of these really fascinating treatments that have been developed for melanoma. I have two patient cases which I will share with you. I have my patient's permission to use their CT photos and their stories. And then I've got a couple of slides at the very end where I'm going to tell you about what I think is going to be the next best clinical trial to come out of the cross cancer. So I do have a few disclosures. Some of the drugs that I'll speak about tonight, their manufacturers have provided research support for us at the cross cancer. And my other disclosure, I only tell happy stories. And it wasn't very long ago in melanoma, that would have been a challenge. So if you were a medical oncologist treating melanoma a decade ago, it was tough to come up with a lot of happy stories. But now I have a clinic every Wednesday morning, and it's not the minority, it's the majority of my patients who are doing well on treatment, and it's all very inspiring. So I just put up this one slide as an introduction, but I suspect you know this. Melanoma is not an uncommon cancer. It's actually the 8th most common cancer in Canada, and there will be a little more than 7,000 diagnoses made in Canada this year. Those numbers translate to an incidence rate of about 1 in 60 Canadians' lifetime. So we all know 60 people. You don't have to work very hard to generate a list of 60 friends or family. And so melanoma is a cancer that if you're not familiar with it, you soon will be, because it's too prevalent, and unfortunately it's one of the few cancers in 2019 with a rising incidence. So we're seeing more cases of melanoma each year as opposed to fewer. And nobody's entirely sure why that is, but something that needs to be addressed. And I would almost say always get asked, well, why did I get melanoma? And it's very easy to jump to the sunlight exposure answer, right? And that's obviously a major risk factor for melanoma, but it's a far more complicated disease than just sunburns. So I'm coaching my son's baseball team this year, so I have too much color tonight. But we've all been on vacations, and we've seen the leatherbacks on the beach, and I don't mean the turtles, who sun themselves day in, day out, and yet they don't seem to get skin cancer. So we know that a person's genetics play a major role. Immunosuppression, whether it's for an unrelated medical condition, can play a role. And then there's also the fact that some of these melanomas are hereditary. So in my practice, I might meet 1 or perhaps 2 patients per year who have a syndromic melanoma, where their mom or dad had a melanoma, and their uncles had melanomas, and their grandparents had melanomas, and those are fortunately rare. But it is a lot more than just sun exposure. So I'll jump right into a case to start talking about what I think is the most interesting treatment, not just in melanoma, but in all of cancer. I met this gentleman, I didn't meet him till 2018. When I did meet him, he was 53, and he was a very well person. So we use a scale in oncology called the ECOG, Performance Status Scale. And well, if you're a 0, you're healthier and stronger than I am, but you're a well person who could essentially do, their activities would be unlimited. And as you move down through 1, 2, 3, and 4, your levels of activity are declining and you're less able to do those activities you'd enjoy. So this was a very well person who had a locally advanced melanoma diagnosed in 2017. He had the opportunity to take a treatment called high-dose interferon, which is not a good treatment, which he wisely declined. As we learn more about melanoma, we learned that some treatments just don't work, and I think interferon is one of those treatments. The box at the bottom of the slide there tells you a little bit about what this gentleman's prognosis was at the time I met him. So following surgery, this is called a Kaplan-Meier survival curve, and of course everybody's alive when they meet their oncologist. Nobody laughs at that joke. I think it's funny. Unfortunately, as a function of time, despite the fact that after surgery everyone's given this clean bill of health and they're told they're cancer-free, we know there are going to be relapses. And so my patient in question would follow this gold line. So we can see that if you looked all the way out to 10 years, he's got roughly a 60% chance of remaining disease-free and alive. So 4 out of 10 of those patients are going to suffer a relapse. And unfortunately, that's exactly what happened to this gentleman. So he opted for surveillance through our melanoma clinic at the K Clinic, which some of you will be familiar with. And this PET scan was done purely for surveillance. He was asymptomatic, but if you've never looked at a PET scan, this scan is like we laid this gentleman in a bread slicer, a bread loaf slicer, and kind of chopped him up into cuts. And he's laying on his back with his feet projecting out of the screen towards you. So this would be the underside of his liver, and this would be his left lung, and that's his heart, which is full of blood, which is full of the radioactive sugar, which we use as a tracer. But this is a tumor. So it's in his thoracic spine, one of the vertebral bodies of his spine. And so meeting him and recognizing him as being well and healthy, I gave him the most aggressive treatment that we could come up with. He had an infusion of 2 of these immune therapy drugs, which I know some of you are familiar with. One is called nivolumab and the other is called ipilimumab, or we often talk about ipi-nivo. And if it's the right patient, I'll often find them on the daycare unit when they're getting their treatment, and I'll ask them why they didn't opt for the BMW. Because one infusion of those 2 drugs is roughly the same cost as a brand new 3 Series BMW. So these are very expensive treatments. But I think you'll see that cost is well worth it. So these immune checkpoint inhibitors, it's not chemotherapy. I go through a similar spiel when I'm meeting patients for the first time, and I do tell them chemotherapy just doesn't work for melanoma. These immune checkpoint inhibitors are actually antibodies. So antibodies are microscopic proteins which our bodies make all day long. And if you were to develop a pneumonia, part of your body's process in fighting the bacteria would be to produce antibodies that would recognize the bacteria. And when those antibodies bind with the bacteria, it's like a beacon or a clarion call for the rest of the immune cells to move in and attack the infection. And this antibody, it's not engineered to recognize a cancer cell, it's engineered to recognize your immune cells, so the white blood cells in your body. And this was such a startling discovery, these immune checkpoint inhibitors, that in 2013, Science, which is the preeminent scientific journal, declared these immune checkpoint inhibitors as their breakthrough of the year, which is really astounding because Science will publish articles on dinosaurs, climate change, and they keyed in on immunotherapy as their breakthrough of the year. And last year, Doctors Allison and Honjo shared the Nobel Prize. So James Allison was the co-discoverer of a molecule called CTLA4, which is the target on the white blood cell for IPI. And Dr. Honjo discovered PD-1, which is the target for nivolumab. And when I'm meeting patients for the first time, I draw a little cartoon on the back side of a piece of paper that tries to illustrate how these drugs work. So again, these checkpoint inhibitors, they don't target cancer cells, they target immune cells, the white blood cells in our body. And these white blood cells have all kinds of proteins on their outer surfaces. So if you were to look at them under a microscope, you'd see that they have molecules such as CD28 or the interferon receptor. And these are all molecules that, when stimulated, turn on the white blood cell. And then conversely, they also express molecules such as CTLA4 and PD-1. And these molecules are inhibitory molecules. So think of them as the natural brakes to the immune system. And when immune cell meets cancer cell, the cancer cells often express a molecule called PD-L1, which is the natural dance partner for PD-1. And when that interaction happens, PD-1 and PD-L1, the immune response is inhibited. So these cancer cells aren't hiding from the immune system. They're actively reaching out and turning it off. Now, if you introduce a drug like nivolumab, or there's others, pembrolizumab, so this is the antibody that breaks that axis between PD-1 and PD-L1, you're able to restore that natural immune response against the cancer, and now immune system wins. And these two drugs, ipilimumab and nivolumab, form the basis of what has really become a landmark clinical trial, and some of you will recognize Dr. Smiley right in the middle there. This was published in 2015, and it has been a very impactful article in medicine. It's been cited over 3,000 times in subsequent studies. And Dr. Smiley and I put about 20 patients on this clinical trial. And this is another Kaplan-Meier curve. So it looks at patients who were treated with either the two-drug combination, as my patient received, Ipi-Nivo, or Nivo, or Ipi. So you could give one drug by itself, or you could combine them. And if you look at these Kaplan-Meier curves, you can see that the best results did come from treatment with Ipi-Nivo. So this is quite astounding. 3 years after treatment begun, almost 60% of the patients who were treated were still alive. And I'll tell you that most of those patients were in remission. So they had had dramatic responses to the immune therapy treatment. And I use a cartoon to illustrate just exactly what that statistic means today for patients with melanoma. So in 2010, which coincidentally was the year before I started practicing at the Cross, so things got a lot better after I showed up. This is a really grim cartoon. So the rate of 3-year survival for a patient with metastatic melanoma, your yellow patients are the ones who are alive at 3 years, and the bluish-greenish ones are those who have died. And so we're talking about survival in the single digits, roughly 6%. And that cartoon gets a whole lot better by 2019. It's really very striking. And I believe, and most of my colleagues believe, those folks who are yellow will stay yellow with time. So 3-year survival doesn't mean you only get 3 years. It just means that's all the follow-up we have from the clinical trial. But I believe those people who are alive and well and who have had these dramatic responses 3 years after treatment will still be coming to see me in 4 years and 5 years and 6 years. So back to our patient. So he received just a single infusion, which takes about 90 minutes. So he's in for one BMW at this point. And he became very, very sick. So I'll talk a little bit about the potency of these drugs in terms of how they can stimulate or maybe even overstimulate the immune system. So he's only 2 weeks into treatment. He's had his first infusion, and he shows up in the emergency department. This is all unbeknownst to me. He's weak, he's dehydrated, he's nauseous. His sodium level is dangerously low, and that probably explains why he had a seizure in the emergency department. Now, his MRI of the brain was normal, but he was quickly admitted to hospital. And it became quite apparent, not only was he nauseous and dehydrated, but he was suffering from a terrible ileus. So an ileus, if you've not heard that term, it literally means that the bowel has just gone to sleep. It's like a paralyzed small bowel. So we're looking at this gentleman in cross-section again, and you can see he's again laying on his back. Here are his kidneys. Well, his abdomen is just massively distended, and this is all air in the bowels. So his intestines have essentially frozen. And he's watched for a time on the internal medicine service, and by now I think I'd had a phone call, or several phone calls. He's slowly improving, but his bowels are certainly not. He's not passing any gas. He's still nauseous and vomiting. And so, not knowing what really was going on, we decide to use what I think of as the antidote to immune therapy. So he receives high-dose corticosteroids. So I'll come back to him in a minute, but we'll talk a little bit about the potency of these immune therapies and how they can cause this hyperactivation of the immune system, which can make patients really sick. So immune-related adverse events. I would venture everybody in the room has met somebody with an autoimmune condition, and it might be Crohn's disease, and it might be rheumatoid arthritis, and it might be multiple sclerosis. But these drugs, they don't cause those diseases, but they can all cause the immune system to behave in a way that looks very much like those autoimmune diseases. And they'll often come on out of the blue 6 or 12 weeks into treatment, but they can occur even after we've stopped therapy, which is why people have to keep coming to see me even though they're living their life and doing fun stuff. They can be mild, they can be severe, or in this gentleman's case, they can be life-threatening. And it's really a laundry list. I've given up trying to tell patients what to expect when they're treated with immune therapy. I sometimes just tell them, pick a body part and add the word itis to it. And it's been reported or we've seen it. So the common ones that we worry about, things like colitis, which is very much like a Crohn's disease picture, or hepatitis, and I don't mean hep A, B, or C, I mean your immune system has decided it's going to attack healthy, normal liver. And I pulled some slides out of a recent article that looks at the prevalence of these immune-related toxicities. And the interesting slide that I'd have you focus on, when things start to go sideways, they tend to really go sideways. So this diagram shows how these immune therapies can overlap. So this poor gentleman here, this number 1 here, he had colitis, and he had myocarditis, inflammation of his heart. There's one or two patients here. This patient had cardiac involvement. He had hepatitis. They tend to cluster and they tend to overlap, so it's not just one thing that can start to cause the wheels to wobble. Now, as you'll see, these toxicities are, for the most part, manageable and completely reversible. So these patients aren't left with Crohn's disease or rheumatoid arthritis, but they can certainly be severe. And some of the questions that might come up when we're talking is, well, why would this person get just one drug and this person gets 2 drugs? Well, part of it is because none of us want to kill a person with kindness. And some of these side effects can be severe to the point where for a patient who's maybe not 53 and not entirely well and not a marathon runner, you might think twice about giving them highly aggressive treatment. So this is kind of a neat cartoon. So remember that CTLA4 is the drug, or the target rather, that ipilimumab or IPI targets. And PD-1, this is the target for Nivo. And there's a rationale for combining these two drugs. Our immune system has small organs spread throughout the body. They're called lymph nodes, and everybody has probably had a sore throat where they could feel a lymph node in their neck. And the interaction between CTLA-4 and its dance partner happens at the level of the lymph node. Now, conversely, this molecule PD-1, it's expressed in all of our tissues. So this just shows pancreatic tissue, but you could look at the liver, the lung, the kidney. These tissues all express PD-1, and that's the natural break to autoimmunity, just to put into context what we're doing when we use these checkpoint inhibitors. And I'll often tell patients, you know, when we combine IPI with Nivo, it's like this atomic immunologic bomb. So when it goes well, it goes really well, but when it starts to go sideways, it can be quite devastating too. So back to this case, we're about a month in now. He's still just had that one treatment. And following that resolution of the ileus, he developed this profound diarrhea and gastrointestinal bleeding. And that picture doesn't really do it justice, but that's a colonoscopic picture, so that's the inside of the colon, and it's just sort of this bleeding, inflamed mess. So now he has to get the granddaddy of all antidotes to immune therapy. He receives a drug called Remicade, which is itself an antibody. And I put this in here just to let you know that as we're developing an expertise with these immune checkpoint inhibitors, we're also developing a skill set that allows us to manage the toxicities. And Remicade, which is a drug commonly used for Crohn's disease or arthritis, so it also costs about what a BMW would, but a really old one. So it's $5,000 an infusion. That's actually not a bad car. It's a little cabriolet. But here's the payoff. So if you're going to spend $40,000 for a single infusion, and he would have had 4 if everything had gone smoothly and he'd not developed any side effects. He actually went on to enjoy this complete response. So this was his baseline tumor right here. And at the roughly 12-week mark, little past 12 weeks, it had completely disappeared. And I haven't updated this in a while, but this all happened last summer, and I've just seen this gentleman. And that picture on the right looks the same today as it did a year ago, despite the fact there's been no treatment in the interval. So while $40,000 seems like an awful lot for a single infusion of treatment, if you amortize that over a year, suddenly it's not as much. If things go as I expect they will for this gentleman, and he doesn't need more treatment, and we do the math in 5 years, it becomes quite a reasonable cost at that point. Does anybody have any questions about immune therapy before I switch gears on that? Yeah? No, you don't pay for cancer care in Canada. That's part of the Canada Health Act. So he actually participated within what we call a compassionate access program. So the clinical trial that showed the benefit of Ipi/Nivo was published in 2015, but it often takes years before that data translates to an approval where the provinces will pay for the drugs. And so the drug company set up an access program so that patients could access therapy in the interim. It's a bit of a complicated process. So because that 2-drug combination had Health Canada approval, the drug company was able to set up an access program. In theory, any drug with Health Canada approval can be prescribed by any doctor for any indication. Now, we don't often do that, right? You wouldn't prescribe this for headaches or something like that. So it kind of depends. It's a case-by-case situation. So I'll switch gears, and I won't talk as much about targeted therapy because although it's fascinating and these treatments have brought tremendous benefit to melanoma patients, I just don't think it's as much fun. But when I meet melanoma patients or any cancer patient, the question often comes up, well, what do you mean, what is cancer, right? That's a very basic question, but not everybody has a real grasp of what it means to have cancer. Well, a cancer cell starts out as a healthy cell, and don't look at that slide. I put that up there just to ask you to not look at it. A cancer cell starts out as a healthy cell, but the difference between a cancer cell and a normal cell, of course, is that the cancer cell has genetic mutations within it. And for 99% of patients, you're not born with these mutations. They occur spontaneously, and they only exist within the cancer cell. Now, about a decade ago, it became known that among the tens of thousands of mutations that exist within most melanomas, one was critically important, and it was a mutation in what's called the BRAF gene. So that is a single protein in a complicated signaling cascade. So a cancer cell and a healthy cell will receive input from its external environment in the form of hormones or other proteins that would interact with a cell surface receptor, and then the way that a signal gets translated from the outside of the cancer cell to the nucleus, which is kind of the command center of the cancer cell, is through the coordination of a number of different proteins, which come together in a very specific and very coordinated way so that one activates another, which activates another. And the ultimate result is that you upregulate proliferation of the cell, you turn on gene expression, the cells become differentiated, the cells divide. And in the specific case of cancer, often the survival signals for the cancer cell are turned on to the point where they can't be turned off. And these natural death signals, which should tell a normal cell when its time is done and it should be replaced anew, they're not functioning either. And the BRAF protein, which is mutated in about 50% of all melanomas, is right at the center of this highly coordinated signaling cascade. So, knowledge becomes power, and once it was known that these BRAF mutations were oncogenic, they were driving the growth of the melanoma cells, the logical step was to develop inhibitors, medications that would specifically block the action of that protein. And we have those drugs now. They come in the form of dabrafenib or vemurafenib. And they've been paired more recently with another set of drugs that block the downstream protein to BRAF, which has further improved patient outcomes. And so I'll just illustrate just how effective these BRAF inhibitors can be. And keep in mind, these don't work for every melanoma patient. We have to look first for the BRAF mutation. It has to be there before we can use these drugs. If it's not broken, you can't fix it. So in this gentleman's case, you can see his melanoma was clustered within the groin, and he did have small pulmonary nodules within the chest, and there's a small tumor in the right lung right there. Slightly older, so 67. He'd had this mass in his groin for many, many months. But otherwise, his disease seemed to be quite well behaved. So we look at this marker, and it's a blood test called the LDH, or lactate dehydrogenase level. It's not specific. It's a protein it exists within all the cells in our body. And when it starts to rise, it's just indicative that we're getting cellular turnover. And it tends to portend a more aggressive course. He was a well patient, but he did have rheumatoid arthritis requiring weekly methotrexate, so arthritis is an itis. So it did give me pause, and it made me think, is this a gentleman where we would start immune therapy? And in fact, we didn't. So this is another New England paper that came out around the same time as the immunotherapy paper was published. And it's also showing a dramatic improvement in our patient survival when dabrafenib, the BRAF inhibitor, is combined with trametinib, which is the MEK inhibitor. And I hope you appreciate just how good these Kaplan-Meier curves begin to look for our patients. So we're getting quite similar outcomes with targeted therapy as we are with immune therapy. So here we are again at 3 years. And the percentage of patients who are alive and in remission, 60%. And like the immune therapy, there's a bit of a signal here. The curve, they used to be these terrible slides that wound up at 0, so there were no survivors with time. But you can all see that that curve's actually starting to flatten out. So it begs the question, are the patients who are still alive and doing well, and it's 60+%, are they still going to be alive at 5 years and in remission at 7 years and 10 years? And I think it's possible. So he went on to start these BRAF inhibitors, and this was a representative scan just to show you how cold that tumor has become. So a PET scan is kind of 2 tests in one. It's the CT portion, which gives us this nice 2-dimensional picture of the body, but that's the tumor there that's absorbed all of the radioactive sugar. Well, there's still kind of the suggestion that there might be some enlarged lymph nodes here, but they're absolutely inert. There's been no spread of the cancer, and they're not able to absorb any of that sugar, which to me indicates he's in a complete response. So I'll bring you back to 2010. I got just a few more slides, and a pretty unhappy cartoon in 2010. In 2019, we'll agree is all better, except that there's still an awful lot of blue patients in here, right? And so what are we going to do for the patients who don't respond to immune therapy, who maybe don't have a BRAF mutation? Well, again, it comes back to this question. What I really like about melanoma, and the reason I think oncology is such a fascinating branch of medicine to practice within, we're moving out of an era where drug discovery used to be about identifying a compound and then testing it in as many cancers as we could to see if it worked here or there or maybe nowhere. We've moved into this era of rational drug design. So you're allowed to use your brain and you're allowed to think. And if you come back to this question, what is cancer? Well, this cancer cell starts out as a healthy, normal cell, but it acquires these mutations, these genetic mutations. And in some melanomas, again, there will be 30,000 plus distinct mutations within a single cell. Now, each of those mutations, each of those mutated genes should correspond to a mutated protein. That's how our bodies work. The genetic material is like the computer code, and the code is a recipe by which proteins are built. And those are kind of the building blocks of the cell. This cartoon you do have to look at. This is a good one. So this is courtesy of my friend and colleague, Paul Lapointe, who's a cell biologist who I'm working with. And I think it's really insidious. If you think back to that first cartoon I showed you where the cancer cell's not hiding from the immune system, it's actively reaching out and it's turning off the immune response. I think that's very insidious. It just makes you realize what we're all up against when we're trying to treat cancer. Well, here's another mechanism which is equally insidious. So every mutated gene makes a mutated protein. And in a healthy, normal cell, all of those mutated proteins would be displayed on the outer surface of the cell so that the immune system could move in and recognize, hey, that's foreign, that's abnormal, that's not right. And then the immune cell attacks the foreign cell. Well, in melanoma, we've learned recently, and in lots of cancers, in fact, these mutated proteins, this little pink globby here, they don't make it to the surface of the cell. They never do get displayed on that pedestal that would lead to activation of the immune system. And it's because our bodies are built with a sort of natural defense mechanism. We have these proteins which we call chaperone proteins. One is called HSP90, and these chaperone proteins prevent these mutated proteins from ever making it into that pathway where they would be displayed to the immune system. And the most exciting clinical trial that's going to run at the Cross Cancer next year is going to be a clinical trial that is specifically designed for all of the blue patients. So those patients who had a crack at immune therapy, but the immune therapy didn't work. And what we're going to do is we're going to use a drug that blocks the activity of this chaperone protein, and we're going to continue on the immune therapy that your tax dollars pay for. And what we've been able to show in the laboratory thus far, when we block the activity of these chaperone proteins, in fact, these mutated proteins do go into this cycle where you get the generation of all of these tiny snippets of mutated protein. And they do make their way out to the cell surface. And it does lead to a much more robust activation of the immune system. And so Megan's sitting here in the front and she's like, yeah, right. Listen to this guy talk. But this is going to be a big deal. I think this is going to turn more of those blue patients yellow. And the goal being, everybody's yellow. And I think we're headed that way. I hope in my career, I hope in my lifetime, we'll see an era where there's a precision treatment for every patient. And the oncologist's job is to match the right treatment to the right patient. And I will finish there and say another thank you, not just to the organizers, but I always like to say thank you to any patients in the audience. It's a pleasure to work with this group of patients. It truly is a pleasure. Melanoma patients are a motivated group. They are an informed group, and when there's an opportunity for a clinical trial, they're always willing and ready participants, which is how we're going to advance the field for everyone. I'm always happy to take emails too. Do you want me to stop and let Kevin move on, or no? Any questions that I can answer? So mole mapping, it's something that dermatologists can better speak to. One of the risk factors that I showed for melanomas, of course, it's the presence of moles. So a person who has 200 moles is at higher risk for a melanoma than somebody who has 2 moles. So mole mapping just involves digital photography, but it has to be done in a very precise way. Probably most people in this room know that one of the sinister features of a melanoma is a changing mole, right? A mole that either gets bigger or gets smaller, and neither of those scenarios is good. So mole mapping is just very precise digital photography that can then be analyzed, and it's not the dermatologist looking at it, it's all done by software that picks up very discrete changes in a mole before you might notice it or a doctor might notice it. So it's coming to Edmonton. I know there is a dermatologist in Calgary who's been mole mapping for some time. I believe there's a dermatologist in Edmonton. I can't remember who it is. If somebody enjoys a complete response, like some of my patients do, presumably you've eradicated the body of cancer cells. I think that curve that was starting to go horizontal there, where patients just weren't dying of their cancer any longer, I have to think that some of those patients have been made cancer-free by their treatment. So you remember that mutation only exists within the melanoma cells. So it's not a mutation you're born with. It's not a mutation you pass down to your children. It's a mutation that started in just one melanocyte, and that melanocyte acquired enough mutations to become cancerous, and then the cascade begins where one cell becomes 2 million. So when the treatment works and when we get responses like that gentleman did, some of those patients may in fact be cancer-free. So you had two 2 siblings who had melanoma,
Right.
and one has passed from melanoma. Well, I don't know, but I know that that's a compelling enough history to start thinking about doing genetic testing. So as I say, that BRAF mutation isn't a germline mutation. It's not a mutation that a person is born with, but there are mutations that some patients, some people are born with that can predispose to the development of a cancer. And there's a cluster of genes that we know about that make some families at quite high risk for melanoma. There's medical geneticists in the city, and there's only a few, and you do have to make a compelling case to interest a medical geneticist. It's not that they don't want to be helpful, it's just they have to screen the general population for those who might truly have some sort of hereditary mutation. And remember, it's less than 5% of all melanomas that are hereditary, so it's a rare scenario. But it would start with a referral to a medical geneticist. That can come from a family doctor, but it can come from a dermatologist or an oncologist. I might make 2 referrals in a year for hereditary testing. Thank you.